welcome to GG classes. Now we are going to discuss about hyperaldosteronism. That means increased aldosterone levels. Because of increased aldosterons, there will be increased absorption of sodium and water through principal cells of cortical collecting. So because of increased absorption of sodium and water, there will be secondary hypertension. In exchange to absorption of sodium and water, potassium will be excreted. Potassium will be excreted in urine. That will lead to hypokalemia. So the main presentation of hyperaldosteronism or secondary hypertension and hypokalemia. So first we should know when to suspect secondary hypertension and hypokalemia. There are various presentations of hypokalemia. So we'll discuss about that. First we'll discuss about the secondary hypertension. So when do you suspect secondary hypertension? When do you suspect secondary hypertension? First, you should suspect secondary hypertension when there is a hypertension in young patients. Second, you should suspect secondary hypertension when there is a resistant hypertension. Resistant hypertension means any hypertension which cannot be controlled by at least 3 antihypertensive drugs, one of which should be thiazide diuretic drug. And these 3 drugs should be at their optimum doses. Even at the optimum doses of 3 antihypertensive drugs, the hypertension is not being controlled. This is called resistant hypertension. Or duration of hypertension is not proportionate with the target organ damage that is seen in the patient. For example, if you had diagnosed hypertension 2 years back, now he has diabetic retinopathy, means that is a disproportionate target organ damage. In these cases also you should suspect secondary hypertension. Or if any hypertension that presents as hypertensive emergency, also suspected as secondary hypertension. Any hypertensive emergency should be treated as secondary hypertension until proven otherwise. So in these cases you will suspect secondary hypertension. The most common causes of secondary hypertension is endocrine causes. The second one is renal causes. But to rule out endocrine causes first, we don't have any one specific test that can rule out whole panel of endocrine causes of secondary hypertension. That is why we'll first do RFT. If RFT is normal, then you should go for endocrine evaluation. If RFT is abnormal, then you should go for renal causes of secondary hypertension. So when RFT is normal in a suspected case of secondary hypertension, then you should first rule out primary hyperaldosteronism, because it is the most common endocrine cause of secondary hypertension. So this is how you trace down from hypertension to secondary hypertension, and secondary hypertension to endocrine cause of secondary hypertension, and then primary hyperaldosteronism. So once you suspect primary hyperaldosteronism, you should do screening test. If screening tests come positive, then you should do confirmatory test. So this is how you suspect primary hyperaldosteronism in a case of secondary hypertension. And the second main heading is hypokalemia. So hypokalemia can also be a part of hyperaldosteronism. So how do you suspect primary hyperaldosteronism in a case of hypokalemia? First, we should know the presentation, different clinical features of hypokalemia, so that we can diagnose hypokalemia first, and then from hypokalemia we can trace down to primary hyperaldosteronism. For that, we should know what are the presentations of hypokalemia. As it is an electrolyte, it mainly affects the function of all the muscles in our body. So first we'll study about muscles. In skeletal and smooth muscles. Because of decreased potassium in serum during repolarization phase. There will be excess potassium outward movement. So excess potassium outward movement because of decreased potassium outside the cell when the cell is undergoing action potential, and when it is in repolarization phase, the excess amount of potassium will be moved outside, and this will lead to hyperpolarization. So this will decrease the excitability of muscle cells. So decreased excitability of muscle cells will present in a different manners, whether it is a skeletal muscle or a smooth muscle. So if it is a skeletal muscle, most commonly it presents as a weakness. So it is presents as acute onset intermittent weakness. So any acute onset weakness which is intermittent, then you should suspect electrolyte causes as the first cause. Weakness progresses from lower limb and then trunk and then upper limb. First, it involves lower limb. And if it affects respiratory muscles, there will be breathlessness. So this is how decreased excitability because of hypokalemia affects skeletal muscles. If it affects smooth muscles, mostly affected smooth muscles are GI smooth muscles, which causes GI distension and abdominal pain. It may leads to vomiting also. How hypokalemia affects cardiac muscle? So in smooth muscle and skeletal muscle, there will be decrease in excitability, but in cardiac muscle, there will be increase in excitability. So in cardiac muscle, there is a specific potassium called K2P1 in conducting system. This K2P1 channel conducts outward movement of potassium normally. Normally, this K2P1 channel present in the conducting system of cardiac muscle will conduct the outward movement of potassium in normal people. But when there is a hypokalemia, this channel, the same channel conducts inward movement of sodium. Because of inward movement of sodium, excess inward movement of sodium through this K2P1 channels, it will cause depolarization of conducting system of heart. So this will cause increased, because of depolarization, this will cause increased excitability. So this is how hypokalemia causes excitability in cardiac muscle, but there is a decreased excitability in skeletal and smooth muscles. So because of increased excitability, you can expect because of increased excitability, you can expect some arrhythmias, tachyarrhythmias. So there may be premature atrial contraction, premature ventricular contraction. There can be ventricular fibrillation or atrial fibrillation, junctional tachycardia. So these are all the arrhythmias which can be presented in hypokalemia patient because of increased excitability. So if any of these two for clinical findings, that is muscle weakness that is acute in onset and intermittent in nature. In this case, and in cardiac arrhythmias. First investigation that we should do is serum electrolytes. If it is a case of hypokalemia, we'll find decreased potassium levels. So once you find out the hypokalemia as a cause of muscle weakness and cardiac arrhythmia, you should evaluate for the causes of hypokalemia. For that, you should know whether potassium is getting excreted in urine in excessive manner, or or the potassium is going inside the cell, so that in serum potassium levels are low. For that, when you find out hypokalemia, first investigation that you should do is urine spot potassium. If urine spot potassium is more, then it means that the potassium is being excreted in urine in excess amounts. So that is why it is leading to hypokalemia. If urine spot potassium is normal, then it means that potassium getting shifted to intracellular side. So intracellular shifting of potassium. So there are wide array of causes for intracellular shifting of potassium. So that is not important in this case now. So if urine spot potassium is more, then the next investigation you should do is blood pH level measurement, that is ABG. If you find acidosis in the in ABG, then it is a case of renal tubular acidosis. If you find alkalosis, then you should measure blood pressure. If the blood pressure is high, that is hypertension, then there are some set of causes. If the BP is normal or low, then there are some set of causes. If the BP is normal or low and the patient has alkalosis and hypokalemia, then the cause can be Bartter syndrome or Gentleman syndrome. If the patient has hypertension along with alkalosis and hypokalemia, then the patient can have five conditions. That is, first one is Conn syndrome, second one is Cushing syndrome, and the next three are called as Mendelian forms of monogenic hypertensions. Those three are Liddle syndrome, apparent mineralocorticoid excess, and the last one is glucocorticoid remediable aldosteronism. So these three are called as Mendelian forms of monogenic hypertension. They are inherited forms and should be suspected in younger patients only. So this Conn syndrome is also known as primary hyperaldosteronism. So this is how you suspect primary hyperaldosteronism in a case of hypokalemia. So now we know that how to suspect primary hyperaldosteronism in secondary hypertension case or hypokalemia case. So there are totally two main presentations of hyperaldosteronism. First one is secondary hypertension. We know how to suspect primary hyperaldosteronism in a case of secondary hypertension, and the second presentation is hypokalemia, and now we know how to suspect, how to trace down from hypokalemia to primary hyperaldosteronism. Once you suspect primary hyperaldosteronism, you should do screening test. For primary hyperaldosteronism, there are two screening tests. First one is plasma aldosterone concentration, and the second one is plasma renin activity. Plasma aldosterone concentration, second one is plasma renin activity. If plasma aldosterone concentration is more than 10 nanogram per deciliter, then it suggests that the case is hyperaldosteronism. If the renin levels are less than 1 nanogram per deciliter, then it means that because of increased levels of aldosterone, the renin levels are being suppressed. So this is a case of primary hyperaldosteronism. This is a case of primary hyperaldosteronism. Once you do these screening tests, and if these screening tests are positive, then you should do confirmatory test. There are 4 to 5 confirmatory tests, but there are only two tests that are important for you. So the first and more preferred one is oral high sodium diet. Oral high sodium diet followed by measurement of urine aldosterone and sodium levels. So in this test, first you should control hypertension and hypokalemia, and then for 3 days you should do oral sodium loading. So the principle of this confirmatory test is, if you give more sodium and water to the patient, it should suppress the aldosterone levels if the person is normal. So even after giving sodium and water in excess amounts, if aldosterone is not being suppressed, means aldosterone is being secreted autonomously. So that is a case. That will be a case of primary hyperaldosteronism. So in this oral high sodium diet, first we should control hypertension and hypokalemia. After that, we should do oral sodium loading for 3 days. After that, we should collect 24-hour urine. 24-hour urine. In that 24-hour urine, we should measure sodium and aldosterone levels. We measure sodium levels in 24-hour urine to know whether the oral sodium loading is enough or not. So if sodium levels in 24-hour urine is more, then that means that sodium sodium loading is enough. Oral sodium loading is enough. If aldosterone level is high, then we diagnose this case as primary hyperaldosteronism. So first we should do two screening tests. That is, first one is primary plasma aldosterone concentration. If it is more than 10 nanogram per dl, then you should do plasma renin activity, the second screening test. If the plasma renin activity is less than 1 nanogram per dl, then you can diagnose this case as primary hyperaldosteronism. For confirmation, you should do oral high sodium diet for 3 days, and then you should do the urine sodium and aldosterone levels. If sodium levels are high, that means that sodium loading is enough for this patient, and aldosterone levels would be reliable. And you should measure aldosterone levels in 24-hour urine after oral sodium loading. If aldosterone levels are high in this urine, then it is a case of primary hyperaldosteronism. And second confirmatory test, and this is a convenient test. Prefer oral sodium loading and testing for aldosterone and sodium. But the convenient test is, so this is a convenient confirmatory test. So the test name is 4-hour saline infusion test. Saline infusion test. In here we give 4 pints of normal saline, that is 2 liters. 4 pints of normal saline over 4 hours. After that we'll measure aldosterone levels. In plasma. If these aldosterone levels is more than 10 nanogram per dl, even after giving saline infusion, then you can confirm this case as primary hyperaldosteronism. So once you know the primary hyperaldosteronism, you should evaluate for the causes of primary hyperaldosteronism. Before evaluating, you should know the causes of primary hyperaldosteronism. So the most common cause of primary hyperaldosteronism is bilateral adrenal hyperplasia, bilateral adrenal hyperplasia. And the second most common cause is unilateral adrenal adenoma, which is functional adenoma. So these two are the common causes of primary hyperaldosteronism. So these two, when you look at these two causes, these two are structural causes of primary hyperaldosteronism. So these two lesions are causing hyperaldosteronism. So to detect these two causes, we should do plain abdominal CT. Plain abdominal CT. So when you do plain abdominal CT, whatever you find, all the lesions that you find in adrenal gland, we divide it into two groups. First one and most important one is if the patient has unilateral hypodense mass that is between 1 to 2 centimeter. It should be more than 1 centimeter and less than 2 centimeter. If all of these features are present, then you group it in first group. If any other findings, if it is normal, if adrenal glands is normal, or if you find bilateral mass, if you find the less than 1 centimeter mass, that is micronodular mass, or if you find more than 2 centimeter mass, that is atypical unilateral nodule, usually more than 2 centimeter. If you find these findings, then you should group them in second group. So the first group, that is unilateral hypodense mass, that is 1 to 2 centimeter, that is more than 1 centimeter and less than 2 centimeter, and it should be hypodense and it should be unilateral. All these three criteria should be satisfied to place it in this group. If in this group patient is not desiring surgery, then you should go for pharmacological management. If patient prefers the surgery and the patient is less than 35 years of age, then you should go ahead and do surgery. What surgery you do? Unilateral adrenalectomy. But if the patient is more than 35 years, there is a chance that this unilateral adenoma is non-functioning. If the patient is more than 35 years. That is why you should do adrenal venous sampling. So you should collect blood from both the adrenal veins and you should do aldosterone renin ratio in right adrenal vein and left adrenal vein, and you should check for lateralization. If there is a lateralization, then you should do adrenalectomy. If there is no lateralization, then you should do pharmacological management. So if what is lateralization, what is pharmacological management, all these things we'll discuss next. First we'll finish off this algorithmic approach. If any other findings, that is in group 2, if the patient is not preferring surgery, then you should do pharmacological management. If patient is preferring surgery, then you should do adrenal venous sampling, and you should follow the same protocol after adrenal venous sampling. That is, first you should do adrenal venous sampling from both the veins of adrenal veins, right and left, and you should calculate aldosterone renin ratio from right vein and left vein, and you should take out the ratio of right and left side. If there is a lateralization, we call lateralization if the ratio is more than 4:1. If the ratio is 4:1, then it is a case of lateralization, and you should go ahead and do the unilateral adrenalectomy. And if there is no lateralization, then you should do pharmacological management. So after unilateral adrenalectomy, in post-operative day 1, you should measure aldosterone levels. If aldosterone levels are more than 5 nanogram per deciliter, on post-operative day 1, then it may be a case of persistent primary hyperaldosteronism. If aldosterone levels are not detectable, then the unilateral adrenalectomy has cured the condition. So in post-operative day 1, aldosterone levels are more than 5 nanogram per dl, then you should suspect persistent primary hyperaldosteronism. In that case, you will measure aldosterone renin ratio. If it is abnormal, then you should do aldosterone suppression test. test. So in this test, aldosterone suppression test, if there is no suppression, then it is a case of persistent primary hyperaldosteronism. Persistent primary hyperaldosteronism. So in this case, you should do pharmacological management. So this is in all algorithmic approach of primary hyperaldosteronism. So what are the pharmacological management that you should do? And in case of primary hyperaldosteronism, so we should give spironolactone, which is a mineralocorticoid receptor antagonist. So the first preferred drugs are mineralocorticoid receptor antagonists. First, you should give spironolactone if patient is not tolerant. If mainly male patients, because of gynecomastia, the patients will be not compatible with the spironolactone. For that, you should give eplerenone. Otherwise, in male patient, initially you can choose potassium sparing, that is amyloride and triamterene. So in this video, we learned a topic primary hyperaldosteronism. Mainly there will be two manifestations. First one is secondary hypertension, and the second one is hypokalemia associated with hypertension. So we know how to trace down from secondary hypertension to primary hyperaldosteronism and hypokalemia to primary hyperaldosteronism. So, and we'll evaluate, you will do the screening test and do the confirmatory test. After confirming PHA, then you should do adrenal CT, and later you should do adrenal venous sampling, and based on the approach you can do unilateral adrenalectomy or pharmacological management. So this in all a topic of hyperaldosteronism. Thank you.